So here's my personal proposal. I would be willing to give up my next year's pay rise as a staff specialist in the system in New South Wales if I knew and got a guarantee that that pay rise would actually genuinely go towards fixing up the New South Wales Trainee Doctor Award and solving some of these problems. A lot of us doctors here in Australia were appalled to hear the news of another story in the last week of a trainee doctor seemingly being exploited by the system. Hi there, I'm Anthony. I'm the career doctor. I make videos on YouTube to help other doctors with their careers. So today we're focusing on the tragic story of Dr Yumiko Kadota, a brave trainee doctor working in plastic surgery who spoke out about her experiences working in plastic surgery at the Bankstown Hospital. Now, I'm a member of a doctors group called the Creative Careers in Medicine group. You can find us on Facebook and on the website. I'll put links in the description. A group of us have been talking about this issue, and rather than turning our thoughts towards anger, we wanted to actually come up with some creative ideas and some potential solutions that maybe haven't been tried here in Australia that might help with these sort of issues in the future. But just before I take you through some of these related ideas, I wanted to get a couple of things clear up front. What I do know is what Dr. Kadota wrote herself on her own blog post and the facts reported in the newspapers. So far, there has been an acknowledgement both by the hospital and New South Wales Health, as well as the College of Surgeons, that there is indeed an issue here. So what we do know is that Dr. Kadota was very enthusiastic and excited to take up her position as a trainee in plastic surgery, something that she would have had to compete with a lot of other doctors to get. But then the problem started. She was added to a roster that she wasn't trained for in ear, nose and throat surgery. She was working up to 12 days straight, 180 hours on call at a time. And people tried to help, but the system didn't move and nothing changed, and it led to a spiral for her where her health and mental well-being started to suffer. The other thing we should acknowledge is that this is a case of doctor exploitation by an overburdened system, but not every hospital in Australia treats its doctors this badly. In fact, a lot of hospitals do very well in looking after their doctors, but it is not an unusual case either. So what is the solution, or what are the solutions? Well, a lot of things have been tried so far to change the culture of poor well-being for junior doctors, bullying and harassment and other things. And we have to acknowledge that no one has the solution. If they did, they would have implemented it by now. We need to be a little bit more creative and look outside what's been tried already and maybe implement things perhaps from other areas of life, other industries that might stand a chance of shifting this problem. So here are 5 ideas that our team came up with. So the first obvious solution is what we're going to call closing the accreditation gap. You see, one of the issues here is that whilst Dr. Kadota is a trainee doctor, a doctor in training, she wasn't actually in training. She wasn't covered by the college that is responsible for surgical training. She was trying to get into that college, and that's why she was actually working the job that she was in. Some colleges are very popular here in Australia, and so trainee doctors will work what's called unaccredited, or what's also called service jobs in the industry, as a way of stepping through to getting to the point of being actually accepted into training. This leaves a very big problem. You see, because those doctors are working in a specialty area under a college, but not looked after by that college, it leaves them open to exploitation. The hospitals are under pressure, and whether they mean to or not, will often exploit those trainees by giving them more additional work because no external organisation is monitoring their safety and well-being. So what's the solution here? Well, one possible solution is for the colleges to step in and recognise unaccredited trainees in their specialty areas and put in place standards for those doctors' safety and training. If the colleges are unable to do that or unwilling to do that, there are other organisations that could. For example, in New South Wales, the interns and residents are looked after by an organisation called the Health, Education and Training Institute. That organisation could also step in and provide an accreditation function, monitoring hospitals, checking that they are implementing safe rosters, checking that unaccredited trainees are actually getting training in their role. So for many years, since actually about 1999, junior doctors, trainee doctors, doctor groups that represent those doctors, including the Australian Medical Association, have been tackling with this issue of safe working hours and trainee doctor wellbeing. We've actually had tools and guidelines in place that most people now recognise. That these tools are commonly referred to as the AMA Safe Working Hours standards. We'll put a link to those in the description below. What those standards do is give those who are involved in developing the rosters for trainee doctors some guidelines and principles to follow, and some tools to work out whether a trainee doctor is being placed in an unsafe position. Patients and their family can help with this by actually asking doctors in hospital about their working conditions and their working hours. It is your right to ask a doctor whether they've had a break or whether they've actually had a really good rest and are capable of performing the procedure that they are recommending for you. Why have we struggled to implement good safe working hours in medicine? Well, part of the problem is that the evidence within medicine is a little bit ambiguous in terms of what is unsafe versus what is not safe. And it's conflicted by the fact that you need to do a level of things and experience in order to get to a level of expertise. So there's a bit of a paradox in terms of how many hours you should work for your own well-being and safety versus how many hours are needed to be worked to get the job done, versus also how many hours you need to work to get the experience up to become an expert in your role. Patients and families can help in this situation by being aware of this problem and even asking doctors in the hospitals about working conditions and whether they've had a rest and a sleep. Now you may ask, well, what happens if you as a family member or a patient ask a trainee doctor this question and the answer is no, I haven't had a rest in the last 24 hours? Well, I think one of a few things is going to happen here. If a patient refuses to have an operation by a trainee surgeon who hasn't had enough sleep, then if the operation is urgent, someone more senior is going to have to step in. And if the operation is not urgent, it's going to be put off to a more reasonable time where it's actually probably going to be better for you as the patient to have it. Yes, that means a delay in terms of being in hospital for a bit longer or coming back, but hey, wouldn't you like to have a safe quality outcome? The irony of this situation with Dr. Kadota is that she is a plastic surgical trainee. In fact, not many hospitals in Australia actually have a 24-hour plastic surgery roster. Many don't even have a plastic surgeon, and those hospitals get by. Dr. Kadota in her blog talked about being woken up and contacted for all manner of things, many of which were not actually urgent and could have been handled by somebody else. Why was this the case? Because there was pressure to keep the patients moving through the system to meet other KPIs. Those KPIs did not take into account Dr. Kadota and other trainee doctors' well-being. Following on from the previous point, one of the issues here that's demonstrated in this particular case is the issue of supply and demand. You see, in certain areas, particularly like surgery, there's a lot of demand for service and not a lot of supply of the doctors to actually provide that service. There's also a labour issue in terms of, as we've demonstrated, a number of trainee doctors wanting to move into that field and only so many being able to get into positions at a time. This creates a bit of a bottleneck, which creates a situation which is open to exploitation in terms of the amount of time that particular doctors have to spend looking after patients. It's a complex issue, but one way we can try and turn it around is by understanding that well looked after and well cared for doctors actually do come up with better outcomes. So if we can get some of those indicators in the system and make the public more aware that a well-rested doctor is likely to treat you better and manage your condition better, then that might actually help to shape things for the positive. The fourth idea is to actually start rewarding the best teachers and supervisors in hospitals. How do we do that? Well, already we have awards and recognition processes, but maybe we should actually start allocating more trainee doctors to the best supervisors and teachers in our hospitals. These teachers and supervisors will look after the well-being and teaching of trainee doctors, and they'll actually get better outcomes from those trainee doctors by actually showing them how to do their job properly and giving them the sort of feedback they need to perform better in their role. For those teachers and supervisors who are not so good, one or two things are going to happen. Firstly, they're either going to improve their skills as a teacher and supervisor and then get more trainee doctors working for them, or they may have to cope with a system where actually they do the work of the trainee doctor themselves. In combination with this, we would propose that teaching and supervision be part of the assessment for senior medical practitioners when they are allocated a job in the system. You see, there's this process where if you're a senior doctor applying for a role in a hospital, you have to go through what's called a credentialing process. This process looks at your qualifications, your training, your skills, your expertise, your experience, and determines the sort of things that you can do within a hospital, the sort of patients that can be admitted under your care, the sort of treatments and investigations that you administer. Rarely does this process, though, look at whether you are a good teacher or a good supervisor and have been trained in those capabilities. And so what happens is that every senior doctor who is approved and credentialed by the hospital is endorsed to teach and supervise trainee doctors and medical students and others. We do not think this should be an automatic privileging process. There should be some scrutiny and some standards in place. Maybe this needs to evolve over a number of years, but it ought to get to the point where credentialing committees look at these sort of capabilities and ensure that those senior doctors actually have the right knowledge, skills and training to look after the supervision and training of their trainee doctors. Our last proposal, and this may come off very controversially, is this. You see, a real problem here in the state of New South Wales in Australia is that we pay our trainee doctors the worst salary in the country. The working conditions of trainee doctors in New South Wales are behind every other state in Australia. The pay is less, and the conditions within the award that support things like wellbeing and training outcomes have not been touched or revised since at least the 1980s. Every year we go through a process of negotiating the awards in New South Wales, and proposed changes are made to the trainee doctor award that might actually support better training conditions. However, every year that is knocked back because that might cost more money. What happens instead is that everyone is just given a percentage increase in their pay. And so the senior doctors do very well out of this, because if you get 2.5% of your existing salary, and that salary might be, say, $250,000, then that's a lot more than the trainee doctor salary when they're earning, say, $60,000 to $100,000. So here's my personal proposal. I would be willing to give up my next year's pay rise as a staff specialist in the system in New South Wales if I knew and got a guarantee that that pay rise would actually genuinely go towards fixing up the New South Wales Trainee Doctor Award and solving some of these problems. And I challenge all of my colleagues in New South Wales to say the same. You've been watching Career Doctor. I hope you found this informative, and I will see you in the next video.